Chapter 25, Nursing Care of Patients with Cardiac Arrhythmias. You can find this in on page 436. This is continuing on with the 6 chapters in cardiac review. This is going to focus on arrhythmias. Okay, so your key terms, learning outcomes are here on page 436. The electrical conduction of the heart is what we're going to be talking about and discussing, and EKGs are used for detecting the rate of the electrical impulses of the heart. So the SA, or the sinoatrial, which is the SA node, is the primary pacemaker of the heart. And so it says here, this is because it's inherent or built in. It is faster than those of the other conduction sites, the atrioventricular or AV node or ventricles. The SA node normally fires at a rate of 60 to 100 beats per minute. Okay, so this is the cardiac conduction system. Okay, 1 heartbeat is a cardiac cycle, electrical representation of a contraction and a relaxation. So this is like anything else. If you contract your fist and relax it, that is simulation of what the heart does, right? So it's a heartbeat. It's 1 heartbeat. So if you can just do that with your hand and you get an idea, that is what a heart activity is. This is the components of the cardiac cycle as illustrated for you here, and it is also on page 437 illustrated. So this is called the PQRST wave, the QRS segment, the QT. So you have different areas that you would measure. Our cardiac physician, which is a cardiologist, you would do a continuous 12-lead EKG. This shows different views of the heart's electrical activity so that you can determine, the doctor will be able to see if the patient has had some damage to their heart. It's going to be, it can be able to be seen here. It's usually a 2-lead continuous monitoring, often in lead 2. EKG graph paper is special paper that is calibrated grids. So those little squares are used for counting, and you can, there's a little device that you use to measure them. So you want to make sure that you review this information about an EKG, what EKG graph paper is. These are all, you can see here, it tells you that 5 small squares is 0.20 seconds wide. So that just gives you an idea here of, this is 0.20 seconds. So you see this, 3 seconds, so that many. So that's why you use that little tool, and it will show you, you can count out exactly how far there is between. And our isoelectrical line or baseline, seen with no electrical activity, straight line produce waves deflect upward or downward from the isoelectrical line. Okay. The P wave is the first wave. This represents atrial depolarization. Okay, so first little wave that you're gonna see is called the P wave. So if you look to figure 25.1 in your book, you can see where that is illustrated. The PR interval is the beginning of the P wave and to the beginning of the QRS complex. So again, figure 25.1 shows that from the beginning of the P wave to the beginning of the QRS complex. Okay. And that is shown for you here, PR interval. QRS waves follows the P waves. The Q wave, first negative, downward motion of the wave. An R wave is the first positive or upward deflection. S wave is second negative deflection in the Q wave, or the first negative deflection after R wave. Not all waves are represented each time. Represents ventricular depolarization. Okay, so this is again a specialty. You don't have to know all of this for, like, have it memorized for each wave and you know what the specifics are. You need to know the basics. You need to know these are not ABC lines, right? They are, the P wave is the first initial one. They're the QRS complex. You need to know what the QRS segment is and where it starts. It's from the P wave, and that is the ends at the R, and that starts for the QRS. So just look at that figure on 25.1. This is what all of this is explaining. You don't need to do not overthink this, okay? You're not going to be cardiologists. So today, for your purposes of what you're studying right now, if you choose to go on and further your education, then you will absolutely be exploring this more in detail. But it is more involved, and so right now we're just learning the basic foundation of what are they talking about. Okay, so here is our QRS, right? So this is the Q, R, S, okay? And then this would be our T wave here. T wave, ventricle repolarization. This follows the QRS wave. So what did I just, this is the QRS, and then the T wave is over here, which follows the QRS wave. So there you go. This is a positive deflection. It's highlighted for you here. So we see here when it's a negative, so this is the way it's supposed to be. If it is negative, that would indicate ischemia. Okay? So this is an irregularity. Okay? So beginning the QT interval, beginning of Q wave to the end of the T wave. These are the normal ranges, so you count these out. Varied based on gender, heart rate, age. Prolonged or shortened QT intervals can lead to ventricular arrhythmias. I worked for a cardiologist when I was like 19 years old. And so I was first joining the medical field as a medical assistant. And I did know what these normal ranges were because the cardiologist that I work for, taught us, myself and the other MA, how to read these and when to call attention to him. We put them all, we did EKGs and then we put them on his desk, but we needed to, and the machine will say if there's an irregular heart rate, but you need to identify. So he taught us how, like if there's a very abnormal, way out of the range here, which here you can see 0.34 to 0.43. So don't think that this doesn't apply to you. You just should know what basic ranges again are, okay? Our U wave is rare. It indicates hypokalemia, and that can come after a T wave. So again, you might not know what is going on, but you should know, like, if there's something extra, something that's irregular, I need to call this to the doctor's attention. Okay, so here is a U wave, and you can see, you may or may not, you might just see a bunch of squiggly lines. That's okay. But if you take a closer look at this now, so this would be an irregularity. Okay. It can be the indication of what? Hypokalemia. Yes. Okay. So ST segments, end of the QRS complex to beginning of the T wave, depressed with non-transmural ischemia, elevated transmural ischemia. Okay, so that is flattened. ST inverted or depressed, and how it's elevated. So again, this is indicating different things here. So what do you need to know? The 6-step process. Regularity of the rhythm, right? So what is the regularity of the rhythm? 2, the heart rate. So you can count the heart rate out here. the P wave, the PR interval, the QRS interval, and the QT interval. These are designated for you on page 440 in table 25.1. I'd like to call your attention there. And that's something that it shows what the step is and what the question is, okay? So you would just ask yourself, like, number 2, what is the heart rate? Okay, I can count it out on this EKG. You can use a caliper and you can measure from the R waves, and it will be able to tell you what those are. So just an idea. Here's R to R. This is what I just said. So you put the point of the caliper here. That's the little tool. And then you put the other one here. These are R waves, right? So this is how we would designate those. And you can also do it by, this is the P wave. So this is showing P to P. So R to R and P to P. Okay, figure 25.9, we're right here. Calculating the rate for a regular rhythm is much easier, obviously, than doing an irregular rhythm. If you look at this closely, I know it's a bunch of squiggly lines, but look, there's a pattern here, right? Even if it's a pattern of irregularity, you're looking at patterns. So does it repeat? Is it every other? Is it every few? So you would start with, what does a regular rhythm look like? This is a regular rhythm, okay? Now we have irregular, calculating the rate for an irregular rhythm, okay? So they are irregular. What's the difference here? Look at that and look at this. You can see these on page 441, and you can look at examining them a little bit more, but basically that is the irregular rate here. That's in figure 2511. The normal one is 2510. Normal sinus rhythm, okay? Normal sinus rhythm rules. It's regular, so you can see like it's counting out regularly. The heart rate is 60 to 100. The P wave is rounded upright before each QRS interval. The PR interval is 0.12 to 0.20. So those little points between where you measure with the calipers, that's what that 0.12 to 0.20 is indicating. And then the QRS interval is less than 0.10 seconds, okay? Arrhythmias, would be rhythm disturbances. So like AFib is probably your most common, most familiar arrhythmia that you know about, that you see. But we have sinus bradycardia. What does that mean? Too slow, right? It's going slow. Sinus tachycardia, too fast, going faster. So here you can maybe just know by just looking your naked eye that these are pretty stretched out, so it's slow. It's going to be less than 60 beats per minute. And so if they have like 50, their heart rate is 50 or something, it's more spread out there. You see these numbers change, okay? That's don't make it more complicated. You can have no symptoms of this. Some people are just that way, or they might exhibit fatigue, and they can faint if it's very severe, not normal for them. There's no treatment if they're asymptomatic. If they're just, their body works that way, then nothing that they'll do. If it's needed, they can do oxygen, atropine, dopamine, epinephrine, and pacing. Okay, here it is sped up, right? So you can see how they were in spread out, bradycardia, and now we have tachycardia. Very easy to see the difference there. This is 101 to 180 beats per minute, right? So they're having a more rapid heart rate. Rounded upright before each QRS complex. This is the difference here. Sinus tachycardia, signs and symptoms, none, or they could be experiencing feelings, pain, angina, dyspnea. They might be more sensitive as they age in the aging process. Therapeutic interventions, treatment cause, medications. These are some of the medications that will be given for tachycardia. Atrial arrhythmias, premature atrial, or PACs they call them. atrial flutter or fibrillation is what you will. And here is, so this person is throwing in some extra, their heart is throwing in PACs, premature atrial contractions. So there's you can count 1, 2, 3. And so this one only goes 1, 2. You see it's an extra, it's thrown in there. Okay, there's an extra one, premature. So P waves, early beat, okay, abnormal shape, usually normal. No signs, you don't really feel this. They can treat the cause if they know what it's coming from. This is flutter, atrial flutter, this you will feel. Flutter waves, you can see here, that does not look like the other ones, right? The normal sinus rhythm. This looks different because all these little waves right there. That's atrial flutter. If you see that, that's like, I need to get the doctor. Or I need to let them know that this person is in atrial flutter. F waves, sawtooth pattern is what it is likened to, a sawtooth pattern. Ventricle, normal rate, rapid ventricular rate, palpitations, angina, dyspnea. Therapeutic interventions to slow the heart rate. Cardioversions can be done. Cardioversions are when the doctor will sedate them and then he will shock their heart to try to get it out of this atrial flutter. So rapid atrial pacing, so it's in a controlled environment and they're able to, it often does work if they do a cardioversion for rapid ventricular rate. They can give them calcium channel blockers, beta blockers, or they can do catheterization ablation. Okay, here we see atrial fibrillation. So these are the irregular RR intervals. So again, they are in places where they should not be. I don't know if you can see that. You see how they're close together? This is spread out. Then these are close together and spread out. Close together. So that is showing fibrillation. It's irregularly irregular. So it's not a perfect, like every one, it just 2 here together, then spreads out. 2 here together, spreads out, then like this one is off. So if you kept going, you would see that there's irregular pattern. Atrial fibrillation is not measurable. You cannot measure this with calipers because it's not regular, so it's all off. Here are your parameters. It kind of just gives you what outlines that is. Palpitations. This person will be feeling that they're having palpitations. My chest feels like it's like flutter. You know, like I can feel something. That's they're describing a palpitation. Okay. They may have a faint radial pulse. They can usually try to do a cardioversion if it's unstable, if it bothers, if they're really feeling palpitations all the time. And then if you, these are the medications that are often given. So anticoagulation therapy is generally always prescribed with atrial fibrillation. They can do an ablation after anticoagulation, surgical maze procedure. So there's other things that they can do. You can, the 3rd degree atrial ventricular block. This is a different type of block that is seen here. And so you can see the different, and this is talking about regular atria ventricles. And so this has a heart rate of 60 to 100. They commonly are within this parameter. Your QRS intervals. Okay, electrical impulses of a 3rd degree AV block, the SA node. So again, you're just going to see that these are different parts of the heart, no relationship between atria and ventricles, P waves versus the QRS complexes, no relationship between P waves and the QRS complexes. So you can see that they're not communicating properly. Causes can be from coronary heart disease and myocardial infarction, from taking digoxin and aging. Symptoms: dizziness, syncope, fatigue, shortness of breath, chest pain, hypotension, diminished or absent peripheral pulses. It's very hard to detect their peripheral pulses. Therapeutic interventions. This is a medical emergency for a third-degree AV block. That will be given atropine, possibly temporary pacemaker, or a permanent pacemaker put in place. Ventricular arrhythmias. These will be coming from a different part of the heart, the ventricular tachycardia and fibrillation. Okay, and this is just kind of illustrating these here. Multifocal PVCs do not look the same. Several irritable areas in the ventricle. So it's all not just in one place of the ventricle. We have repetitive patterns of the cycle here, and you will get into bigeminy for every other, every third, quad, right, every fourth beat. So it just indicates what type of rhythm that they're in. Bigeminal PVCs. So this is bi. They will feel any of these arrhythmias. They're going to be feeling palpitations, dizziness, fatigue. Those are kind of generalized. Okay, here's ventricular tachycardia. That looks abnormal to you, right? P waves are absent completely. Signs and symptoms. Okay, CPR is going to be as initiated here. Defibrillation, epinephrine, amiodarone, lidocaine. This is obviously emergent. That's ventricular fibrillation right there. So you can have an idea of what that looks like. It's chaotic, extremely irregular, not measurable. They'll be unconscious. This is not someone that's walking around with this generally. They'll be in respiratory arrest, pupil dilation, and have cyanosis. ACLS protocols are initiated and put in place. CPR. Asystole. What does asystole indicate? Death. There's no anything happening here. They are unconscious, absolutely. This is like they have fallen into a arrhythmia that an irregular heart rate that if you are able to start it with CPR or a defibrillator, then that is your best shot at getting them back into a regular sinus rhythm. Dual chamber heart pacemaker, EKG tracings, ventricular only. So this gives you just what the different areas of the heart, why, and how they monitor them. Yeah, if you have a pacemaker, you cannot have an MRI. They have to have different types of testing for any of that. Electrical shock, okay, for lethal, saline pads, conductor jelly. So, okay, this is here. Placement of a defibrillator, the defibrillator pads across the chest because they're going to hit the heart. It's in the middle, right? That's what the impulses are meant to hit the heart in the middle. So you have one, it's on either side of the heart. This allows R waves to be sensed for safe delivery. This is a synchronized cardioversion. So they sedate them and they'll give them a 25 to 50 joules of electrical impulse. Again, the cardiologist will do that. And implantable cardioversion defibrillator. This is so whenever the heart goes into a VT rhythm, that implanted cardioverter will just fire and it will shock the heart out of that rhythm. Our review questions.